Hello, everyone. Thank you for joining. We'll be starting this Global Ground Rounds conference with a short message from Dr. Oye. After that, Dr. Sangodeyi will take over.
Sounds good. Thank you.
YouTube ads is made for your business.
Greetings and welcome to our Global Ground Rounds for July 12th, 2025. It's our pleasure to have you all join us from all parts of the world. We take this program very seriously as an educational tool for many of our students and physicians, and as a means to continue to share knowledge between and amongst physicians and non-physicians alike. Today we have an exciting group of young physicians who will talk to us about exciting case studies relating to limb salvage and wound care. I am excited also to say that the program is brought to you by the Oye Global Medical Foundation and Uzima Medical Foundation. Unfortunately, today I cannot be there in person due to family commitments. However, the program will be taken care of and coordinated as well as supervised by Dr. Sangodeyi, General Trauma Surgeon at Raleigh General Hospital and a member of the Uzima Foundation. Dr. Sangodeyi has a long experience in general surgery and trauma surgery and will be an excellent moderator for the program. I'd like to offer my congratulations to the students ahead of time for hopefully a wonderful presentation, and also for the audience for indulging our young doctors who are the future of medicine to enable them present to you on this day. It is our goal that the students will use as a medium to improve their ability to speak on the global stage. Without further ado, at this point, I will hand the program over to Dr. Sangodeyi and the young doctors. Thank you very much.
Well, I'm Dr. Sangodeyi. Good morning, everybody. I'm very happy to be involved with this program. We thank Dr. Oye and his group for continuing to make this a reality. Vice President of the Uzima Foundation, which is also part sponsor of this program. As you know, Oye Global Medical Foundation is the main sponsor of this program. We have excellent speakers today. At this time, I want to also introduce Dr. Brown White, who is our excellent vascular surgeon. He will definitely, thank you. He will definitely answer all the tough questions that may come from the audience. I'm not a vascular surgeon anymore. I used to do quite a bit in my younger age. As I age, I kind of slow down a little bit. So I'm so glad that the speakers are ready, queued to go. And I want the audience to ask tough questions so that we can really drill the speaker and they can answer a bunch of questions. And Dr. Brian White is here to support me if need be. It's unfortunate that Dr. Oye has to fly to New York early this morning because of some family emergency, but I'm here to support him as best as I could. Our first speaker is going to be Jay Prashar, that will be talking on acute and chronic limb ischemia, managed with hybrid techniques. It's going to be a case report and literature review. Jay, your turn.
Thank you, Dr. Sangodeyi, for the introduction, and Thank you everyone for joining today. Is it good? Sorry, we're just setting it up. Get the screen going.
Yeah.
Okay, so I'll be presenting acute on chronic limb ischemia managed with hybrid techniques, a case report, and literature review. Acute on chronic limb ischemia is a vascular emergency that can lead to severe complications, including significant morbidity, limb loss, and increased mortality rates. This case report illustrates a case of acute on chronic limb ischemia addressed using a combined surgical and endovascular approach. The report includes an in-depth discussion of diagnostic techniques, the technical details of the intervention, and strategies for post-op care. Additionally, a literature review is provided covering current research on hybrid techniques. So a little on the learning objectives. So I'm going to be talking about recognizing the key clinical features of acute on chronic limb ischemia, understanding the diagnostic modalities and their application, and I'll be doing a review of the hybrid endovascular approach for limb salvage. And finally, I'll be moving on to discuss outcomes of evidence supporting hybrid techniques in complex cases. So moving on to the introduction. So peripheral artery disease is a widespread vascular condition with increasing global prevalence, leading to significant healthcare challenges and patient morbidity. Acute limb ischemia, characterized by a sudden decrease in limb blood flow, requires immediate revascularization to prevent permanent damage to the tissues and potential limb amputation. The situation becomes more complex when acute ischemia occurs alongside chronic arterial insufficiency, necessitating strategies for effective limb salvage. Hybrid techniques, which combine open surgery and advanced endovascular procedures, have been shown increasingly to provide better outcomes. This review and case report examine the role and success of hybrid therapies with particular focus on the use of drug-coated balloon technology. Case presentation. So our patient was a 52-year-old male with significant cardiovascular history, including chronic heart failure, hypertension, prediabetes, and a history of bilateral deep vein thrombosis, managed with apixaban, presented with acute on chronic limb ischemia symptoms affecting his left lower extremity. The patient reported instances of pain and necrosis of the left toe persisting for over 2 weeks. On clinical evaluation, signs of advanced ischemia, including stenosis, significant edema, and gangrene were noted. Laboratory studies revealed systemic inflammatory response indicators such as leukocytosis with a white blood cell count of 12.2, elevated lactic acid, and hyperbilirubinemia, all of which are consistent with our diagnosis of severe ischemic insult and secondary infection. Diagnostic evaluation. So urgent CTA confirmed extensive thrombotic occlusion involving the distal left superficial femoral artery, the SFA, extending to the distal popliteal artery. Additionally, significant occlusion was observed in the right profunda femoral artery. Intervention and initial attempts at anterograde recanalicalization were unsuccessful due to chronic organized thrombotic lesions. Consequently, a hybrid surgical endovascular strategy was selected. An open below-knee incision provided direct retrograde access to the popliteal artery, facilitating mechanical thrombectomy using both Fogarty and mechanical thrombectomy aspiration catheters. Subsequently, angioplasty employed a 6 millimeter by 150 millimeter drug-coated stent balloon, significantly enhancing arterial patency. Final completion angiography revealed successful restoration of arterial blood flow. Surgical closure involved meticulous use of 6O proline sutures and advanced Surgiseal application to ensure optimal hemostasis and provide minimal post-op complications. And a little on the figure. So as you can see here, in this image, we have intraoperative fluoroscopic image showing retrograde access to below knee popliteal artery via open surgical exposure with a Fogarty catheter deployed for mechanical thrombectomy. And in the first figure, we had pre-op CTA demonstrating extensive thrombotic occlusion of the left superficial femoral artery, extending to the popliteal artery with collateral vessel formation consistent with chronic disease progression. Okay, and now moving on to a little bit of the literature review. So for the literature review, we had hybrid techniques, combine open and surgical endovascular approaches, and they maximize benefit, minimizing limitations. And then according to the TASC2 guidelines, Norgan et al. Emphasize disease severity stratifications, advocate multidisciplinary integrated care models, drug-coated balloons, reduced restenosis rates in FEMPOP disease, advocate multidisciplinary integrated care models, drug-coated balloons reduced restenosis rates in FEMPOP disease, meta-analysis support enhanced patency and fewer re-interventions. And then for rapid revascularization, Shish-Benner et al., the multidisciplinary team displayed improved outcomes, and Syracuse and Kashup, hybrid techniques safer for high-risk patients. And then lastly, we had retrograde popliteal approaches with Pooley et al., effective in complex lower limb occlusion. Okay, and then moving on to our discussion, the integration of open surgical thrombectomy with advanced endovascular techniques, including drug-coated balloon angioplasty, present distinct advantages in complex ischemic cases. Hybrid interventions leverage strengths from both techniques. Endovascular methods offer minimally invasive, precise interventions, while open approaches allow for comprehensive thrombosis clearance and direct vessel assessment. Unique aspects of this case include patient severe cardiomyopathy, which posed additional anesthetic and pre-op management challenges, underscoring the safety and efficacy of hybrid interventions even in high-risk patients. The successful outcome in this case reinforces the hybrid surgical endovascular strategies facilitated by close interdisciplinary collaborations are not only viable, but they're also advantageous in complex clinical scenarios, such as this patient with a 5 to 10% ejection fraction, traditionally associated with high complication rates and poor prognosis. In conclusion, this detailed case report exemplifies the successful application of hybrid surgical and endovascular techniques for managing acute on chronic limb ischemia. A comprehensive literature review affirms hybrid interventions as essential for complex vascular conditions, highlighting multidisciplinary approaches and advanced technologies crucial for optimizing clinical outcomes, particularly in high-risk patient cohorts. The hybrid strategy allows for retrograde surgical access to clear thrombosis effectively. Thank you. And here are my references, and thank you, everyone. If you guys have any questions, my email's on the slide. And once again, thank you, Dr. Oye, for being the preceptor in this case, and thank you, everyone, for watching. Thank you.
I have one question. Hey, Jay, are you there?
Yeah.
Hey, what's going on? Good to see you.
How do?
Yeah, so I wanted to ask, when this patient presented with acute on chronic critical limb ischemia, did you guys were you able to find any signals on Doppler when they presented?
So originally this case was actually goes against like what we usually think. So this case actually they presented at a bigger hospital and they were brought here for a second evaluation. And when they did a second evaluation here, they actually found that they could salvage. Before they were thinking about doing a whole leg amputation, below the knee amputation. But based on what they found here, we were able to just do the great toe, which was necrosis. So we were only able to just dissect the great toe. If that answers your question.
Okay, great. And I also wanted to ask, and again, this is no right or wrong answer, just basically your opinion. Do you think that this patient would benefit from a bypass in the future?
For sure. I think that maybe in like in 3, 4 years, sometimes like we find that when it happens with one leg, that we would move on to the next leg. But I'll get Dr. Oye to further expand
Yeah,
on that
that's
question.
no problem. Very good. Thank you for that presentation.
Thank you.
How,
One question,
no.
this one I need to say to you. Did he have profound disease? You said he had profound
disease, yeah.
Gotta be very careful. There's always something that I teach my residents. The profunda keeps your leg alive, the SFA makes you walk. We didn't say anything about the profunda here. You may get away with this now, but if this is a patient who had a belly ejection fraction, he probably would have benefited more from a common femoral opening laterectomy,
Okay.
profundoplasty. You go ahead, Dominic, do what you need to do at the same time. Great job. I mean, with an
Thank you.
injection fraction of 10 to 15%, I agree with you. Get the leg open, get it salvaged. But he's somebody you need to follow very carefully, because with stents or as an angioplasty and poor runoff, this could go down pretty quickly.
Yeah.
So you have to have a plan in place of what's your next step. But great job.
Thank you. Thank you, Dr. White. Any other questions? Sorry.
How old was the patient, and how do you think that this will last for the rest of his life? I don't know how to. Will it last a month, a year, 10 years, depending on his age?
He was a 52-year-old male. So like he was a 52-year-old male. Usually like when we do an amputation on one leg, usually like my preceptor, I've heard him say it many times and I've read it online as well. It's like usually like when they get one leg done, usually the chances are that in a few years, in 4 years, 5 years, they're gonna have to get it done on the second leg as well, just because of the complexity of the case. And if you guys can expand on that.
The specific question he's asking, how long will this particular leg last? And it's important because, like I said before, runoff is important. We didn't address below, we just addressed this inflow. And as I looked at that film, it looked like he had significant disease in the tibial vessels. So normally when you talk about runoff, blood has to go somewhere.
Yeah.
And if there's no way for it to go, it eventually fails. Okay. So the question he's asking is, how long will you think this will last? I mean, we may have gotten him out of the acute phase, but you really have to follow him down the line, because 9 times out of 10, this may last 3 months, this may last 6 months. And that's why the importance of the profunda is very important. Again, the SFA keeps you walking, but the profunda with collaterals will eventually, with an amputation that you do, will keep an amputation going and take him away from another intervention again. Okay, so that's the key here.
Great answer. Thanks so much. The last question is, did you mention the predisposing condition? Is he diabetic? So young.
He was diabetic, yeah. He had congestive heart failure. He was diabetic.
Yeah.
And he had several of the risk factors.
Gotcha. Thanks so much.
And it really goes in with the patient population here, because here obesity is, I believe it's #1 or #2 in all of America. It's like we're on the higher scale, like and this like just small area, like there's some more things need to be done on like a social, economic side of it. I feel like on the cultural side of it, more interventions, like just pre-op, like just before a patient even becomes a patient, like including more gyms, more education, more resources for maybe underserved populations. And I feel like us as students maybe could get more involved in that aspect of it as well, if that's something that we can continue to do in our education and through our time here in West Virginia.
Good for you. An ounce of prevention is worth a pound of cure.
Yeah.
Good. Yeah. Great. Thank you for expanding on that.
Thank you, Dr. Wilson.
Got a question from Dr. Arja.
Dr. Arja?
Yeah, I have, good presentation. I have a simple question. What resources did you use for your literature review? What are the databases?
So I have, I put them in the references. Let me, sorry, it's a.
Oh, no worries. It's okay. No.
Like I have a list of references over here, and then on the on my case report and my literature review, I have it all typed up. I have all of the references that I use in the databases and everything. I can send that to you after this presentation, if that's something that you're interested in. Thank you.
Thank you very much.
Dr.
Thank you very much, Jay.
Thank you.
I appreciate your input. couple of comments. I saw the cardiac ejection fraction was about 5 to 10%.
Yeah.
Did anesthesia group give you any problem with that, with approving for anesthesia? Did they give you any headache?
I put it in my report that it could have been a complication, but we didn't. I don't remember like what the anesthesia said.
Yeah, because our concern in our hospital is that such a risky patient frequently always want to be turned down by anesthesia, but I'm happy that you're able to help this patient. The other thing was that what is nicotine use? Or does this guy use a lot of cigarettes?
In his past medical history, I didn't see anything about nicotine use. He did use alcohol. It was in the history, but I didn't see anything about nicotine use. And he was diabetic and other risk factors as well.
Obesity?
Obesity, yeah. Okay.
Well, thank you very much, Dr. J. It's interesting that he mentioned the prevention social aspect of this disease, which we all need to be aggressive about. Yes, there's a lot of risk factors that make you end up like this. And as providers, as physicians, as medical provider, we really need to focus on prevention. That is my take most of the time, is how to prevent this disease. It's a lot cheaper to prevent than to be treating these complicated cases, but we were just not there yet. But globally, this is something we need to really focus on that we're not focused on. So I thank you very much, Jay.
Thank you, Dr. Sangodeyi.
Good. The next presentation is there any other question from the audience? If not, we will go to the next presenter, Ibrahim Ibikunle, to talk about open retrograde popliteal approach to revascularization. Thank you, Ibrahim.
Thank you, Dr. Sangodeyi. Let me just pull up my presentation. All right. Okay. Hello, everyone, and thank you for attending this event. Before I begin, I would like to thank Raleigh General Hospital for allowing us as students to participate in such interesting cases. I'd also like to thank the Oye Global Medical Foundation and the Uzima Foundation for sponsoring and organizing this event. And I would like to thank my mentor, Dr. Oye, for his guidance in putting together this presentation and this case report. So my topic is titled The Open Retrograde Popliteal Artery Access for Revascularization of an Occluded SFA with Bilateral Iliac Artery Stenosis. So I'm going to be talking a bit about the definition of the peripheral artery disease. Then I'll delve into the patient's presentation and why they came into us and why they came into the clinic. I'll talk about the procedure itself. I'll use mostly the fluoroscopic images that we were able to take. Seeing as this was an endovascular procedure, most of the procedure was done using catheters and wires and fluoroscopy. Then I'll talk about how the patient did post-operatively and how her follow-up case and her follow-up period went. And we'll discuss about things that we can take away from this presentation. So peripheral artery disease. What is peripheral artery disease? It's a circulatory condition in which there's a narrowing of the arteries that reduce blood flow that supply blood flow to the limbs, and especially affects the arteries that supply blood flow to the lower legs. It is primarily caused by atherosclerosis. However, it's accelerated by conditions such as diabetes, uncontrolled hypertension, and smoking. Now, the symptoms of peripheral artery disease can be remembered by the mnemonic, the 6 Ps, and those include pain, and this pain is often associated with activity. So the patient could be walking or running, and they would experience pain in their limbs. The pain in severe cases could also be present at rest. Another symptom is pulselessness, in which you feel a loss or diminished distal pulses. The next common symptom is paresthesia, which is a medical term for abnormal sensation or tingling. A late symptom would be paralysis, in which a patient would have muscle weakness or they would have an inability to move their limbs. And finally, or fifth, the next symptom would be pallor, which is due to the diminished blood supply to the region. And finally, the last classic symptom would be poikilothermia, which is a fancy term for cold leg. So there are many ways to treat peripheral artery disease. These two, balloon angioplasty and stent angioplasty, are just a few. The kind of methodology behind them is the same. You insert a wire and a catheter into the diseased artery or diseased vessel. In balloon angioplasty, you simply inflate a balloon to push the plaque that is compromising the artery up against the vessel lumen wall. And then you remove the balloon, and obviously the end result is revascularization of the artery. And in stent angioplasty, you follow the same technique, insert a wire, a catheter, and in this case, you expand a stent into the area of stenosis, and that stent compresses the plaque and stays there in place. They both offer their own advantages and disadvantages. So the patient's presentation, our patient was a 65-year-old female who presented with bilateral leg pain. She said that the pain was greater on her right side, and she also had difficulty walking. Her physical exam was unremarkable besides the pain. Her Doppler showed like very diminished blood flow in the lower extremities. Her past medical history was significant for numerous comorbidities. The patient was obese. She had hypertension, hypothyroidism, dyslipidemia, non-insulin dependent diabetes mellitus, fatty liver disease, and GERD. So you can see this patient is, well, she has a cocktail of diseases, and we definitely factored her comorbidities into her treatment plan. So given her symptoms, we ordered an ABI, and for those non-physicians in the audience, an ABI stands for ankle brachial index. And what we essentially do is we measure the blood pressure in the ankle and the blood pressure in the arm or the brachial artery, and we kind of compare and make sure that they're equal. In a normal person or in a normal individual, the blood pressure in the arm and the blood pressure in the ankle would be equal. However, in this patient, there was bilateral moderate stenosis, and her ABI or ankle brachial index was reduced because the blood flow to the leg was decreased significantly. So given this abnormal ABI finding, we went on to do a CTA with runoff. A CTA is a computer tomography of the vessels with distal runoff. And in this image, you can see the CTA with runoff, the aorta. Let me put on this laser so you can see my right here. Okay, so the aorta right here is patent. However, when it divides and bifurcates into the common iliac arteries, you can see that there's some degree of stenosis in the common iliac bilaterally. That would explain the patient's bilateral leg pain. And if you look at the distal vessels, on the left side, the SFA, the profunda, they're all patent. The popliteal artery, they're all patent. However, on the right side, there's diffuse atheromatous changes in the SFA. The patient has almost completely occluded SFA, and there's profound and pronounced collaterals on the right side. So we went and took the patient to the OR, and we performed an endovascular, the classic endovascular procedure in which we accessed the left groin. We were able to percutaneously cannulate the left femoral artery, advance the microvenous needle, advance the microvenous wire, and then we upsized to a 4 French sheath. We then passed the glide wire up into the abdominal aorta and performed an arteriogram. An arteriogram is basically us injecting dye into the lumen of the vessel, and then that dye kind of contrasts against everything around it. And you can see here the aorta is patent. However, the iliacs bilaterally are stenosed. We estimate it to be around 40 to 60% stenosis on the iliac arteries. So having done that, we were able to then cross our wire from the left side over here to the right common iliac. We were able to do that using a universal flush catheter. And after we did that, we were able to then advance down the iliac into the femoral artery. And then when we reached the femoral artery at the bifurcation of the profunda and the SFA, we did another arteriogram and shot some dye down. And as you can see in this image here, which is magnified even further, it is you can appreciate that this vessel right here, the one that my pointer is on, is significantly stenosed. However, this vessel right here is more patent. Now, I want to take a moment to talk about this image because we noticed in this patient, and it's caused some initial confusion, that the patient had an abnormally positioned SFA. The SFA is the superficial femoral artery. As you can see in this illustrated diagram here, the SFA is supposed to be medial to the femoral artery, the femoral profunda, sorry. However, in this patient, her SFA was lateral to the profunda. And this caused some initial confusion because according to normal anatomy, this vessel right here, the one that looks more patent, would be the SFA, as it's more medial. However, we're able to identify that this was a profunda because if you look down at the image, at the bottom of the image right here, this branch is the first perforating branch of the profunda. And so using our knowledge of anatomy, we're able to determine that this was the profunda and this was the SFA right here. This significantly stenosed vessel over here is the SFA. And we're able to then plan our treatments and plan the next steps accordingly. So we try to pass a guide wire and a catheter through the SFA, and multiple attempts to do that were unsuccessful. And and then there was also a dissection of the SFA, and so this warranted us to abort the anterograde approach, and then we had to go through the retrograde approach. So you can see here we went into the popliteal artery. We tried to initially percutaneously access the popliteal artery using a microvenous needle without opening the skin. However, because of the small caliber of the patient's vessels, as you can see, this right here, the vessel loop wraps around the popliteal artery, and it's extremely small. And because of that, and because of the fact that the patient also had significant calcifications on her popliteal artery, that made percutaneous access to the popliteal artery difficult. And so we had to open the patient. We made a small incision, dissected through the subcutaneous tissue and fascia, and under direct visualization, perform a cannulation of the popliteal artery. Once we did that, when we confirmed that we were in the true lumen of the popliteal artery, we then injected some dye, and we saw that we're here. Right here is the area of dissection, confirming that we're in the true lumen of the popliteal artery. So our next step was then to advance a hybrid guide wire from the popliteal artery up into the occluded SFA, and we're successful in doing so. As you can see here, this is the wire went up from the bottom right here, which is the popliteal artery, and we went into the SFA. So now that we had access to the popliteal artery and the SFA using the wire, we then performed a balloon angioplasty of the SFA. We used a drug-coated balloon. This drug-coated balloon was coated with the drug paclitaxel, and the point of using a drug-coated balloon was to prevent restenosis and maintain the patency of the vessel. So as you can see here, we inflated the balloon. This image right here kind of shows these kind of indented areas, which are areas of stenosis. We then continued to inflate the balloon more and more until finally over here we had the balloon fully inflated. And once we're done, we deflated the balloon and shot some dye to check if the SFA was indeed patent. And as you can see here, the SFA was very patent in both of these images, and we confirmed distal blood flow because we did another fluoroscopy of the lower extremities below the knee region. You can see here the popliteal artery, and it branches off into the anterior tibial and the posterior tibial artery. And so this allowed us to successfully confirm that we had supplied distal blood flow to the popliteal region and the anterior and posterior tibial arteries. So recall in the beginning that that the patient had stenosis of her bilateral iliac arteries, and after treating the SFA, we're able to advance a wire into the iliac artery on the right. We then proceeded to perform balloon angioplasty of the iliac artery. As you can see here, this is the right iliac artery. We're inflating the balloon into it, and then we use the left groin access point for the balloon angioplasty of the left iliac artery, as you can see in these images here. And now you can see the before and after images. Here's the before image that we performed at the beginning of the procedure, with the patent aorta and the stenosed iliac arteries bilaterally. And here's the after image. You can see that there's a much more robust and increased blood flow through the iliac arteries bilaterally. So having done that, we then proceeded to close the patient. The left groin side was closed using a closure device. And for the open popliteal region, we closed the arteriotomy with 6 Orpoli sutures, and we closed the fascia and the subcutaneous tissues with vertical sutures. And after we're done closing, or before we've completed closing, we actually inserted a JP drain and Jackson-Pratt drain to make sure that there's no residual bleeding or fluid accumulation in the area we operated in. And after the procedure, we confirmed the DP and the PT pulses, that's the dorsalis pedis and the posterior tibial pulses with the Doppler ultrasound, and those were found to be present. So post-op, how did the patient do after? The very next day, her JP drain was removed, and it showed minimal bloody discharge, and the patient was allowed to go home the very next day. She was discharged on 81 milligrams of aspirin and 75 milligrams of Plavix daily, and she was told to follow up in the clinic in a week to remove her stitches. And 1 week later, we saw her in the clinic. She had positive Doppler pulses bilaterally. She reported improvement in her leg pain. However, she had some moderate or like mild edema in her bilateral lower extremities. And so that warranted us to kind of delay the removal of her sutures by another 10 days. However, the patient did report a significant improvement in her leg pain and her claudication. So what can we take from this case? What can we kind of derive from how we treated this patient? Well, first, this case demonstrates successful revascularization of a completely or nearly completely occluded SFA, and we used endovascular techniques. Endovascular surgery was able to reduce the patient's hospital stay, and that allowed the patient to go home the very next day. We were able to prevent a femporal bypass, which would have been the alternative to treat this patient's occluded SFA. And the femporal bypass would have been an open surgery with a prolonged hospital stay and with more prolonged exposure to anesthesia, etc. And that would have had its own risks. The retrograde popliteal approach that we used allowed us to gain access to the right SFA, allowed us to gain access to the femoral arteries, the iliacs, and had we wanted, we could have crossed over and accessed the left iliac as well. So we could eventually, or in theory, treat all the areas of stenosis, the SFA on the right side, the right-sided iliac stenosis, and the left-sided iliac stenosis using only one access point. So that was an advantage or potential advantage of a retrograde approach. We were able to also facilitate the cannulation of the true lumen using the retrograde popliteal approach. Now, another thing we can take away from this case is the importance of an in-depth knowledge and understanding of human anatomy, even when we're dealing with complex or what we would term simple vascular cases. Challenges such as small caliber vessels, such as this patient, or vessels passing unorthodox routes, such as also in this patient who had her SFA more lateral to the profunda, could pose as obstacles during surgery, but they can be overcome by properly identifying the vessels, knowing what branches they give off, etc., etc. Not included in this presentation, but was involved with another case in which we did a carotid endarterectomy on a patient, and the patient's vagus nerve was found to be lying on top of the carotid body and the internal carotid artery, and that's obviously abnormal as the vagus nerve is supposed to be on the lateral aspect of the carotid body and running lateral to the internal carotid artery. However, by correctly identifying and knowing what we're looking at in surgery, we're able to sort of reroute and work around these obstacles and overcome them. So to conclude, this case demonstrates a successful revascularization of a nearly completely occluded SFA using endovascular techniques. This highlights the effectiveness of endovascular surgery. Endovascular surgery is still rising and is still improving every day. And we also encourage the consideration of a retrograde popliteal approach to performing iliac angioplasty. And it also urges viewers to brush up on their anatomy, as patients may present with variations in their vessel routes, and in-depth anatomical knowledge leaves less room for guesswork while in surgery OR. Thank you, everyone. If you have any questions, I'd be glad to answer.
Do we have any question for Ibrahim?
Yeah, it looks like Justine, and then I have a question too.
All right, go ahead, Justine.
Hi, Ibrahim. That was a really interesting case presentation and really, really well done. My question is, would a covered stent have been a viable alternative in this patient? And could you elaborate on the benefits of using the drug-coated balloon instead of a coated stent, particularly in terms of long-term outcomes or complications?
All right, that's a good question. A covered stent could have been used. However, we elected not to use it for a number of reasons. First of all, a stent does carry its own risks, and it carries its own sort of complications, the stent could be restenosed, and that could also, because if the stent was placed in a vessel, it would also compromise the ability to access that vessel or work through that vessel in the case of future interventions. Also, if you look at the image of the SFA, or when we did the balloon angioplasty, the areas of stenosis and the areas of disease of this patient and her SFA was very long. And so if you're to place a stent in the patient, it would have to place either multiple stents or a very long stent, and that wouldn't be ideal. And to answer your question about the drug-coated balloon, the drug-coated balloon is advantageous in the sense that it uses medication to kind of maintain patency of the vessel, and that allows blood flow to adequately reach the distal extremities, and also it prevents long-term restenosis or long-term occlusion risk in the future. Hope I answered your question.
Hey,
Very well
Ibrahim,
done. Thank you.
I just wanted to add on to that. Whenever you're using a covered stent, you have to be very cautious because you're also cutting off collaterals once you put it in place. So you have to be very cautious using covered stents.
Yeah, that's absolutely correct. Thank you, Christo. Like Dr. White said, the SFA keeps you walking, but the profunda keeps your leg alive. And the collaterals in this patient, as you saw in the initial CTA, the collaterals were the only thing that was kind of maintaining some sort of blood flow through the SFA. And so it was very important that we allowed the patient to still have those collaterals. And in the case of restenosis, those collaterals allowed the patient to maintain blood flow to the distal extremities. Thank you, Christo. Lanny Wilson, Dr. Wilson?
That was an impressive understanding of anatomy. I'm glad that you pointed that out and showed that. That was great. Drug-coated balloons, how long does the drug stay on the balloon? Doesn't it get washed away pretty quickly?
Well, I'll allow Dr. White to kind of.
First of all, I mean, I'll hit all those things. Excellent presentation. But I got some questions I need to ask him. Tell me about ABIs. How do you measure an ABI? Sorry, guys, we regress here. I'm over teacher. Tell me about an ABI. How do you measure it?
So we measure the brachial artery blood pressure, and then we also measure the blood pressure in the ankle, the dorsal pedis for the posterior tibial arteries blood pressure, and we kind of divide the blood pressure in the ankle arteries by the blood pressure in the brachial artery, and see the ratio or the index in between.
So if somebody's blood pressure in the left arm is 170 and the right arm is 150, okay?
Yeah.
And the ankle pressure is 170 on the left and 170 on the right. What's the left ankle brachial pressure? What's the right ankle brachial pressure? This is important. I see this a lot. Okay, and this is really a foundation. You can do this in any part of the world. You don't need an arteriogram. If you know how to calculate an ABI accurately, that's about half if everything is there. So what's the person's ABI?
Can you give me those numbers again so I can do them?
Let me make it easy for you. In terms of ankle brachial index, you have to measure blood pressures in both arms. Use the highest of the blood pressure in the arm. So if it's 170 on the left and 150 on the right, you have to use the highest. Why is that? Because they could have disease in proximal from the subclavian brachial X-ray. That's important. Because sometimes I do a lot of ultrasounds with people and they bring the wrong ABI. So you need to remember that, okay? How to measure ankle brachial index. It's important. Okay. I'll get to your drug-coated question. The other thing that in this particular case is beautiful pickup with the anatomy in the common femoral. And did you guys handle it a right? Was it the right side? Did you do a right model? Okay, that's important. Because if you don't, you will get mixed up. You have to do a right oblique to see how those vessels take off on the bifurcation. Okay. The third thing in this case, and you elaborated it excellently, this patient had a robust profunda. It was literally feeding the right lower extremity. Again, collaterals. With the covered stents, you don't want to use that. You want to keep your collaterals intact. I don't use covered stents. I really use stents below in the femoral area. A lot of people do it. I find that once you put a stent in, the stent literally is an increased risk for restenosis. And you begin to chase that, you got to take clot out. So unless the patient dissects the long segment, or it's a chronic occlusion of long segment, and once I open it up, balloon drug-coated, which lasts for about a couple of months, and it falls off. Okay, it prevents restenosis of that vessel. I will live with that. I could always go back and intervene. But covered stents and any stent, in particular in the SFA, I try to avoid it. Okay, so that was excellent.
Thank you.
And the third thing I want to run by you is when you send patients home, they should be on 3 medications: aspirin or Plavix, aspirin and Plavix, or now it's what's the other one?
Berlanta.
Well, yes, no, not that. The campus study, Lovenox, not Lovenox, Xarelto 2.5, and Plavix is a study that was done by Compass. It's an excellent study. Okay, and the most important thing these patients need to go home on is a statin. Okay, they have to be on those 3 medications. Any vascular patient should be on those 3 medications. So please make sure they have those medications on board. And if the doctors don't present it, you write it, because it's shown to decrease mortality in all vascular areas. So they need to have that. Okay.
Just to mention, because of the patient's comorbidities, he already had dyslipidemia, so he was already on a statin.
Okay, all right.
Yeah.
You said, okay, very good. But otherwise, and the other thing that you need to understand, CTAs are good. It sort of gives you an idea where your disease is. But a lot of times they either underestimate or overestimate the disease, especially in below the knee or even in the SFA. So they may say you have about a 40% disease, but you get in there, especially with calcified patients, diabetic, hypertensive, renal failure patients, you look at a severe calcification throughout the entire vessel. Okay, so keep this in the back of your mind as you go through this. Okay, very good.
Thank you. One more question from Dr. Wilson. You got...
Yeah. Just to finish up. Those were great answers. In fact, that was one of my questions about how long you would keep a person on those medicines. Probably not just post-operatively, but for the rest of their life, probably.
I never stop it.
Yeah, good. Excellent. And the last observation, I was glad that you described the closure of the wounds. Sometimes, and it's important to do meticulous closure, because sometimes people have complications from just their wound closure. So you don't want that to be an added hassle in the postoperative period. Thank you for that great presentation.
Thank you, Dr. Wilson. Yeah, we got one more question in the audience. Ola.
Hi, thank you. So I just wanted to ask, how do you decide when to proceed with either endovascular intervention or open bypass, especially in patients that have like a really complex anatomy or maybe like a more severe disease?
So we based that decision based on several factors. This patient had numerous comorbidities. She had hypertension, obesity, dyslipidemia, and because of those comorbidities, she was already a poor candidate for an open surgery or open bypass, any sort of major surgery, actually. And also, the endovascular techniques that are used today are so advanced that we can actually use them as first-line treatments, even in severe cases or complex cases. And so the endovascular techniques that we used were able to successfully revascularize the patient in this case. We would, however, go on to perform a fempo bypass or on other forms of open surgeries if the endovascular surgery or endovascular techniques didn't work. However, because of how advanced the technology is, we were able to avoid that, and we hope the endovascular surgery will just keep advancing and keep improving so that we can prevent opening up patients, especially in this day and age where as the first presenter said, the rates of obesity are so high, and the rates of all these comorbidities, diabetes, and end-stage renal disease are so high. Preventing open surgeries and open major procedures would be optimal.
Okay.
Thank
you.
Is that all? Any questions? All right, thank you.
Yeah, let's give it a round of applause for Ibrahim. I think he did a good job. Again, you could see the problem with obesity. This second patient was also very obese. So we deal with this in our beautiful West Virginia. I understand West Virginia, Alabama, Mississippi are the top place for obesity. If I'm wrong, please correct me. I used to be in Denver, Colorado, and I used to see people very skinny, like number ones. And but here is a lot different way. So for the people who are vascular surgeon in the audience, how often do you see abnormality of vessels anatomy like we have on this case? Is this a common problem, 2%, 1%? What do you think, Dr. White?
In our population?
For the abnormal anatomy of the blood vessels.
That's 10 to 15%.
So this is quite a bit, about 10%, but like Ibrahim said, you just have to be aware of your anatomy and be ready to deal with all this kind of problem. Is there any other questions from the audience for Ibrahim?
I need to answer, just elaborate on something. Wasn't Ms. Justine, you asked the question just now. One of the things you have to be very careful with endovascular surgery is that, endovascular surgery and percutaneous operations have really moved vascular surgery along. I agree with that. But one of the things I'm beginning to see is that a lot of people doing endovascular work are not thinking that sometimes a simple bypass would not help. I was brought up in the open era, and I have done a lot of open surgeries. But we really have to evaluate these patients really well, because at the end of the day, they still have disease that we're leaving behind, whether we're doing an atherectomy, an angioplasty, a stent. And we have to really evaluate these patients really well. And sometimes a bypass, a FEMPA bypass with vein or even with graft, a simple open common femoral endarterectomy in the groin, instead of trying to put 2 wires down and trying to open them up. An open procedure sometimes is the best way to fix these things for long-term benefits. So I need us to be very careful. I know everybody say endovascular, percutaneous first. We have to look at the patient's comorbidities, age, life expectancy, and all those things, and really take those things into consideration before we make decisions on percutaneous only. Very careful, please.
A very, very good comment, Dr. White. We appreciate your input on this. And I'm going to move to the next topic. Next speaker is Sekinat Olaboopo.
Good morning, ladies and gentlemen, my esteemed colleagues, respected doctors. It's an honor to have you here today. My name is Sekinat Olaboopo, as Dr. Sangodeyi has introduced, and I'm a third-year medical student at Avalon School of Medicine. Today, I'll be presenting a fascinating case that I came across during my surgery rotation with Dr. Herbert Oye here at Sheily General Hospital, and it's titled Limb Ischemia and Non-Healing Ulcers in Iliac Occlusion. Today, I'll walk you through an introduction to the case, the patient's case presentation, our diagnostic steps, our intervention, and most importantly, focusing on critical decision-making that led us to select an endovascular approach instead of open surgery, and how it affected this patient's outcome. And then we'll talk about the patient's postoperative outcome. To start with the introduction, ischemia, as most of us know about, is basically the lack of blood flow to an organ, and it can affect any organ of the body. And when we say critical limb ischemia is the most advanced stage of peripheral artery disease, as Ibrahim talked about earlier, and it's usually characterized by severely reduced perfusion to the extremities, particularly the feet and legs. And patients present with persistent rest pain, non-healing ulcers, tissue loss or gangrene, and usually they have absence of palpable distal pulses. But in the early stages of the disease, patients usually present with intermittent claudication, which is basically absence of pain at rest and pain with movement. But as the ischemia progresses, patients present with more painful pain even while they're at rest, and this often leads to skin breakdown and ulcer formation. The root cause of chronic limb ischemia or peripheral artery disease is atherosclerosis, but we also have other risk factors such as diabetes, smoking, hypercholesterolemia, obesity, and other factors. As we know, diabetes causes high blood sugar, which causes non-enzymatic glycosylation of blood vessels, and as a result of this, it causes damage to endothelium of the blood vessels, and it impairs angiogenesis. And for smokers, cigarettes contain nicotine, which causes constriction of blood vessels and platelet activation, which also hinders wound healing. Then we have other general factors such as genetic factors like family history, obesity, sedentary lifestyle, and other factors. So to our case presentation, our patient is a 63-year-old male who presented to the emergency room with progressive left lower extremity pain and multiple non-healing foot ulcers. Patient states that he had the pain that has persisted for over a year, but the pain wasn't over the past week. He has a medical history of diabetes mellitus, hypertension, and permanent pacemaker. And he also stated that he smokes about 1 pack of cigarettes for as long as he can remember. So as you can notice, our patient has a lot of risk factors for the development of peripheral artery disease, such as diabetes mellitus, the smoking, and his uncontrolled hypertension. So before I go on to explain our diagnostic finding, I'd like to brush up our anatomy knowledge of the aorta. Here you can see the abdominal aorta, and at the point of the fourth lumbar vertebra, it divides into the common iliac artery and the right and left common iliac artery. And the common iliac arteries divide into the external iliac artery and the internal iliac artery, and the external iliac artery continues as the femoral artery. So now to our diagnostic findings. We performed a CTA of abdomen with lower extremity runoff, which showed complete occlusion of the left common iliac, internal iliac, and external iliac artery. And as you can see in the image here, the left common iliac artery is completely occluded, showing no sign of blood flow to the extremity. However, our patient had some collateral circulation, which maintained blood flow to the left common femoral artery and prevented like total ischemia of his left lower extremity. Also, we performed a vascular duplex ultrasound, which was to confirm if the patient had left lower extremity deep vein thrombosis. However, our patient showed no sign of deep vein thrombosis, which confirmed that the symptoms of our patients was mainly of arterial origin and not of venous origin. So before we intervened in this patient, we carefully weighed operative risk and cleared the patient with cardiology. Our patient had a pacemaker on, and they confirmed that the pacemaker was stable. He had it was stable. He had no acute ischemia, and he had no arrhythmia at the time of operative clearance. However, our patient had increased risk for infection, as he had a colostomy bag on. He also had an uncontrolled diabetes mellitus, and he was an active smoker. So considering all these risk factors, we decided that it was more feasible and more it was better for the patients to go to treat him endovascularly instead of with open surgery. So now to the operative details. We proceeded with an endovascular revascularization under fluoroscopic guidance. Percutaneous access was achieved using a microscopic needle upsized to a 4 French sheath to establish access to the iliac artery. And after this, we used a glide wire to navigate the total occlusion of the external iliac artery and the common iliac artery. And after this, we successfully re-entered the true lumen of the aorta, which is a critical step in ensuring proper stent placements later on in the procedure. And as you can see in the image here, we performed an aortogram, which is basically like X-ray to visualize the aorta of the patient aorta. And you can see there is absolutely no blood flow in the common iliac artery here. The patient had near total occlusion of the left external iliac and left common iliac artery. So after confirming this, we proceeded to use a mechanical thrombectomy device to debulk the thrombus and the atherosclerotic plaque. And this step was like a vital step to restore the lumen patency of the aorta. So we removed the thrombus and the plaque that was in the patient's aorta. After debulking the thrombus and the atherosclerotic plaque, we proceeded with balloon angioplasty. Balloon angioplasty is basically to ensure dilation of the narrowed segment of the external iliac artery and the common iliac artery. And in the external iliac artery, we use the 6 millimeters by 40 millimeters balloon to dilate the narrowed segment. And you can see as the different stages of the progression of the angioplasty. Yeah, so different stages of progression of the angioplasty. Sorry about that. So after angioplasty, we proceeded with stent deployments. In the external iliac artery, we used a 7 millimeters by 58 millimeters covered stent. And in the left common iliac artery, we used 10 millimeters by 58 millimeters stent. And this balloon expandable stents was to ensure precise deployment and full apposition to the vessel wall and minimize the risk of stent migration or endoleak. And you can see the image on the left is the picture before intervention, and you can see there was complete occlusion and no blood flow through the common iliac artery. And on the right was after intervention has been done, and you can see a patent blood vessel and with blood flowing through it. So this was the completion angiography, and it showed excellent stent expansion. We had restored anterograde flow through the iliac axis and through the common iliac and the external iliac axis. And we had no evidence of distal embolization in these patients. So we confirmed this. After this, we checked the patient's pulses using the duplex ultrasound, and we confirmed restored blood flow to his lower extremities. And now let's expand on why we opted for an endovascular approach in this patient rather than an hybrid approach or open surgical approach. So first, our patient had a colostomy bag on, and if we had gone through the open surgical approach, the patient would have a very high risk of getting infection or even proceed to sepsis, as the bowel flora could, leak into the open incision site or the site of the site of the incision and lead to infection or even progress to sepsis. Also, our patient has a lot of comorbidities like diabetes mellitus. He had chronic tobacco use, and he has uncontrolled hypertension. So these risk factors together would increase and decrease the patient's wound healing. And if we had gone with the open surgical approach, the patient would have risk of developing wound dehiscence, infection, and prolonged hospital stay. So a minimally invasive approach significantly lowers the patient's tissue trauma and supports faster healing in these patients. Also, our patient was on pacemaker, which showed that the patient had probably an underlying conduction disease or prior cardiac compromise. And open vascular surgery would involve longer anesthesia time, more fluid shift, and higher cardiovascular stress. However, with endovascular approach, the patient's surgery was performed under local or moderate sedation, and it minimizes the anesthetic risk. Also reduces the loss of blood. And as I've said earlier, the patients would have a faster recovery rates and reduce systemic stress if we treat endovascularly as compared to open surgery. So after the intervention, we noticed excellent stent apposition. As you can see here, the patient's feet look well perfused. Initially, when the patient came, he had no palpable pulses. He had discoloration of his extremity. He had cyanosis. So we were able to achieve restored blood flow to his foot, to his left foot, and we noticed no perioperative complications. And the patient came back to the hospital for follow-up, and we noticed proper wound healing of his ulcers, of his foot ulcers on his toes and his leg, and he also reported reduced leg pain. And that'll be all for my presentation. Please let me know if you have any questions.
I have a question. So would a hybrid approach, like a femoral cut down with iliac stenting, have been a safer or more effective approach?
Yeah, in some instances, yes. But as I said, in our patient, he had a colostomy bag on. So any kind of incision, regardless of if it was hybrid or open surgical approach, would increase the patient's risk of getting infection. So that's why we decided to go with no incision approach at all.
Thank you.
What sort of hybrid approach you think when you say hybrid, what are you talking about here?
Endovascular and surgical. Using both.
So this patient, and again, remember when I was saying earlier on, you have to know exactly how you select and what you do. This is a classic case of that. This patient, once you get through the iliac on the left, okay, percutaneously, that's the only way you go here. Okay, this is a classic case of where you don't cut percutaneous in, up, stent out. Okay, but also you have to make sure that in patients like this, if you notice the iliac stenosis began right at the bifurcation, you have to make sure that there is no disease in the aorta proximally. Because if a patient has proximal aortic stenosis, okay, or on the right, you could end up with a failed stent. Okay, so but this is done perfectly. There's no the only other procedure to do here was a right to left fem bypass. And with all of his comorbidities, that's definitely off the table. You don't want to have incisions on a guy like this. So this is it. This is what we do. Okay.
Okay, that makes sense. Thank you.
Do any other questions from the audience?
Yes, see. Do we have any other questions? Lily's iPhone.
Hi, good afternoon.
Good afternoon.
All right. So I have a quick question.
Okay.
Well done. I'm new to this group, but I was wondering, which thrombectomy device did you use?
Okay. So according to my preceptor, we're not allowed to disclose the thrombectomy device name because it's like we are advertising for the company. So that's why we did not state the specific thrombectomy device we used.
But it wasn't an atherectomy device?
No.
Because thrombectomy device is different from atherectomy device.
No, it's a thrombectomy device.
But it's able to remove the atherosclerosis as well?
Yeah, as well as the thrombus.
Okay. And did you protect the contralateral common iliac?
Excellent question.
Did you protect it, or you just went ahead with your thromboembolectomy?
What do you mean, did we protect it?
Excellent question.
Yeah, I like Dr. White comment on that.
So what she's saying is, if you can do a thrombectomy on the left side, okay, whatever device you use, there's a small possibility they could flip thrombus on the right side, okay? She's asking, I mean, I was going to bring it up, but I didn't want to. She's asked a phenomenal question that people forget. You went up to that aorta, whatever you're using, nothing was done wrongly here. You got to be very careful. Whether it's a thrombectomy device, a device that atherectomizes the thrombectomy, whatever it is, you have to watch out for the other side, okay? Because if you don't, you will know a couple hours later on, the patient could present right extremity pain. You know what happened? You just embolize the right side. Phenomenal question. So, excellent question.
Thank you, Lily. So any other questions?
Yes, Dr. Wilson here. What was the reason for the colostomy, and what's the stage of that disease? Thinking holistically, when you're treating someone, I mean, if he had advanced cancer, he's going to die tomorrow. You don't want to be doing this stuff. But if he has a chance of living longer, then you want to help make him in as good a health as you can. So, simple question: what was the cause for his colostomy?
Okay, so particularly, I do not know is the GI comorbidity that he had, why he had the colostomy bag on, because this was, as I said, he came to the emergency room. It was like an emergency procedure. So I personally do not know the reason why he had the colostomy bag on.
Okay, it's just a good idea to know the whole patient, not just one part of the patient. So, this is a teaching moment. I'm not criticizing or anything like that, but so thank you for a good presentation.
Thank you.
Is there any other question from the audience?
I just wanted to add that was a really good presentation, and I liked the part that you said that this could happen in any part of the body. Here at Marshfield, where I'm training, we have acute on chronic mesenteric ischemia come in, and these are, sclerotic vessels that can be throughout the body. So if somebody has, coronary artery disease, they will have probably vessels in their legs, vessels in their abdomens. So it's something to keep in the back of your mind as well, that these don't just come by themselves.
Thank you.
Yeah, Christo, since you said that, and maybe this is for the experts, could his colostomy be related to some kind of a non-cancerous condition that may have been a vascular related problem in his abdomen?
Very unlikely.
Unlikely?
Very
Okay.
unlikely. Yeah, very unlikely, because we don't know. This could have been just a temporary colostomy, or it could be something that was for various reasons. So
Okay.
Now, if you want to push further, with his cancer, did he get radiation therapy? That caused radiation vasculitis. You got to think about that.
which can
But
cause,
very unlikely. Now, you brought up something that's also important all over the body. I try to let all the students know an abnormal ankle brachial index is a marker of peripheral or atherosclerotic disease throughout the body. Okay, and that's the reason why you have to know to do an ABI properly, because if they have it in their legs, they have it in the heart, they have it in the neck, they have it in the mesenteric vessels. Exactly like what Dr. Aja said. And guys, this is so important. People miss it. If a patient comes to you with an ankle brachial index of 0.5 or 0.6, it's a marker of severe cardiovascular disease. And that's the reason why these people, you have to get them on the aspirin, statin, and Plavix. You have to get them on best medical management. Smoking is the most important. Vascular medicine is a field you guys should really pick up and roll with it. It's an amazing field. If you get these patients and take care of them before they get to this point, you have a good chance of them doing well. So just remember the ABI, abnormal marker of vascular disease. And I've had a lot of patients that I have come to my office and do a procedure on them. I said, oops, send it to the cardiologist. They get a stent. They feel better, the blood flows better, and sometimes they don't have to operate on them. Cardiac issue goes away, and they feel better. So always think about how we're doing it. Okay? Very good.
Thank you.
So,
Do you have any questions?
Like the doctor said, holistic approach, global thinking, all this is very important. Thank you very much, Sekinat. Very good job. Okay, well, we are making good time, and I'm very happy that everybody is asking some good and tough questions. The one question for Sekinat, what kind of perioperative antibodies did you use in this case? Do you remember? Dr. White, what kind of perioperative antibodies were you using in this case?
Oh, I'll just continue the answer.
You just continue the answer. Yeah, I'm always surprised that ANSEV is still the prophylactic antibodies in most surgery. I don't usually agree with it because when you look at the gram for ANSEV, just doesn't cover nearly anything anymore. But that is still the recommendation.
Really not treating anything with the bowel, not treating colostomy.
I understand, but
and percutaneously, really.
Yeah.
And some people wouldn't even use anything.
Yeah. Well, so this is the open for discussion, but I'm always wondering, ANSEV is the recommended stuff that we use most of the time. There's so many possibilities for the colostomy, but we don't have enough time to get into that right now. So the last presentation, a group of students that will talk about innovative strategies on CERAB. Sheily, Umang, Sheetha, they will come and present.
Hello, everyone. Good morning, and thank you all for joining in. I would also like to thank Dr. Oye for giving us an opportunity to present today. So I'm Sheily Jain, and me and my colleagues will be presenting on innovative CERAB strategies today. We'll be talking about what is CERAB, how it is advantageous over open surgery, and what was our experience till date using the CERAB strategy. So first we'll talk about peripheral arterial disease, which is a condition where narrowing of the arteries causes decreased blood flow to the limbs. It is present in more than 12 million Americans and 200 million individuals worldwide. Critical limb ischemia, which is a severe form of peripheral artery disease, affects 1.3% of the adults in the United States with an incidence of 3,500 cases per million per year. Smoking, hypertension, diabetes, sedentary lifestyle, genetics are some of the risk factors for peripheral arterial disease. It presents with mainly leg pain, absent pulses, foot ulcers, or gangrene. And to evaluate the peripheral arterial disease, we can do an arterial study with ABIs, CT angiography, MRA, and catheter angiogram. Talking about Ledder's syndrome, it is an aorto-iliac occlusive disease involving the distal aorta and iliac arteries. It is typically caused due to atherosclerosis and presents with intermittent claudication, gluteal claudication, absent or decreased peripheral pulses, and erectile dysfunction in males. The demographic most commonly it affects is in men over the age of 50, and with risk factors including diabetes, hypertension, smoking, and hyperlipidemia. For diagnosing Ledder syndrome, we use abdominal ultrasound with color Doppler and CT angiography, and severe restriction of blood flow due to atherosclerosis to the lower extremities can lead to limb-threatening ischemia. So what is CERAB? CERAB stands for Covered Endovascular Reconstruction of Aortic Bifurcation. It is an endovascular procedure which is used to treat aorto-iliac occlusion. In this procedure, we use 3 stents, 1 stent covered stents. 1 stent is used in placed in the distal aorta, and 2 covered stents are placed at the bifurcation to restore blood flow and improve outcomes. It is a minimally invasive procedure with low complication rates compared to traditional open surgery, and also offers better durability and compared to using plain kissing stents. So why CERAB? It is indicated for patients having high-grade occlusion requiring revascularization and is used in end arterectomy when excessive common femoral, superficial femoral, and or profunda atherosclerosis is present. It has a shorter recovery time and better long-term patency compared to kissing stents. Also, hybrid intervention can be performed using CERAB, and using the CERAB technique, a glide wire advance from the brachial approach can be captured in the femoral artery, either through open surgical exposure or percutaneously using a snare, which facilitates precise stent deployment. So this is an image showing a kissing stent versus a CERAB. So in kissing stents, there are two stents placed from each iliac artery and which meet at the bifurcation. This restores flow, but it can also cause turbulent blood flow due to the mismatch and overlap at the bifurcation, which can lead to restenosis or thrombosis over time. In contrast to CERAB, we use 3 stents, covered stents, the distal aorta and 2 in the iliac arteries. This creates a smoother flow pattern and it mimics the natural anatomy, which improves the patency rates and reduce complications. So why is CERAB preferred over open surgery? One, because it is minimally invasive, so there are lower risk of complications. It also has shorter recovery time and better long-term patency in the aortic occlusion cases. CERAB technique has emerged as a preferred option for improving outcomes by reconstructing the aortic bifurcation in a more anatomical and physiological way. For diagnostic workup, we have clinically absent femoral pulses on physical examination. We use CT angiogram to define the extent of occlusion and on-table catheter for diagnostic and confirmatory arteriogram via femoral break approach. For treatment decision, when is CERAB indicated? When there is high-grade occlusion present, when there is distal aortoiliac occlusion, and when we need to avoid aortobifemoral bypass, CERAB is a better option. Okay, so now I'll hand it over to my colleague Umang, and he'll walk us through the next part of the presentation.
We should wait till we finish all the presentation before we ask questions.
So I'll talk about the technique of the CERAB which we use. So the first step is to get vascular access. So we percutaneous intervention is the first line option, and we do that via the bilateral femoral arteries. In case percutaneous intervention is not possible because of excessive plaque in the common femoral or the superficial femoral profunda, an open endarterectomy can be used with passage of cannulation of the iliac and the aorta in a retrograde fashion. So, and if dissection is a problem, a brachial approach can be used where you go through the arm and capture the glide wire via the open femoral arteries or percutaneously with a snare. After we get vascular access, an aortogram and iliac arteriogram is performed for detailed visualization of the occlusion. An occasional balloon infarction of one iliac artery is performed to facilitate cannulation of contralateral common iliac via brachial approach. So in case there's less infarction of one iliac artery, we can use that to gain access to the contralateral in case there's excess blockage there. And angioplasty of the common iliac is done with a smaller 5 to 4 millimeter balloon, and after that a larger balloon and covered stents are passed to the aorta and iliacs for deployment. The stent placement for aortic reconstruction improves primary inflow channel, and balloon angioplasty optimizes the stent expansion in the aortoiliac arteries, ensuring proper patency and blood flow. And a completion endarterectomy with or without patch, depending on vessel size. So in case of an open endarterectomy, when a vascular access is not possible, the endarterectomy can be closed with a patch depending on the vessel size. The final arteriogram is used to confirm the good circulation throughout the treated vessels. And I'll go through some cases which we did using the CERAB procedure. So in the first image, in this first image, you can see there's almost complete blockage of the common iliac on both the sides, but we were able to pass a wire from the right side to the left side, and also again from the left side to through both the right and the left common iliacs. This is the passage of the wire, and we can also perform lithotripsy if needed in case there is excess occlusion and atherosclerosis. After passing the guide wire, the iliacs can be ballooned to widen the lumen, and the aorta is also ballooned. After ballooning them, we can see there's there is increased blood flow. In case a stent is needed to be placed, we can first place the stent in the aorta You can see it's placed in the aorta here, and then we can balloon and place a stent in both the common iliacs together within the aortic stent. So this follows the anatomical and physiological blood flow of this mimics the anatomical and physiological blood flow. This is another case with extensive blockage of the iliacs and with collateral circulation. So this is a chronic case. We were able to pass wires through both the common iliacs into the aorta. We then used balloon angioplasty to widen the lumen and place stents. This is on this we can see there's aortic stent placed, and the common iliacs, in both the common iliacs there's stent placed within the aortic stent. And finally it showed good blood flow. This is a third case where there's blocked iliacs on both the side, but there's extensive collateral circulation, so which provided blood flow to the distal parts. Think we weren't able to pass a wire, if I remember correctly, about this case. So we had to go through the brachial approach and get a snare from the right common iliac. We were then able to balloon it and place stents within the aorta and the iliac. These are the balloons, and this was the final arteriogram with much robust and clear patent blood flow. Okay, I'll let my colleague talk about the complications next.
So complications. So as with any advanced endovascular technique, CERAB isn't without risks. The most common complication is arterial dissection, which occurs in about 10% of cases. But importantly, these are typically manageable by identifying the true lumen and using a stent. Other complications include iliac artery perforation, ischemic bowel, distal embolization, and lymphocele, which occurs in about 2.5% of the cases. Mortality is very rare, especially in experienced hands. The main takeaway is that while complications still exist, most can be anticipated and successfully managed. So, key reasons why CERAB may not be feasible in Lerer syndrome. Now, despite its amazing benefits, CERAB isn't suitable for every patient. For example, complete iliac occlusion leaves no channel for a guide wire. Severe aortic thrombus or circumferential calcification increases the risk of embolization and limits stent. Active infections or mycotic lesions are absolute contraindications. And severe iliac tortuosity or scarring can prevent proper stent delivery, and sometimes there's simply no femoral access due to prior occlusions or surgery or poor distal runoff that limits benefit. Finally, prior complex stents or grafts can leave no adequate landing zones for the stents. So careful patient selection is therefore very crucial. So this is one of the cases where we couldn't pass the guide wire. So our experience till date. So in our series of 42 patients, the results have been very encouraging. We had no deaths, and dissections that occurred were successfully managed by re-entering the true lumen and stenting. We were unable to complete stenting in only 2 cases. There were 2 lymphoceles and just 1 iliac perforation, which we treated promptly with a covered stent. Most patients were able to go home the same day or after just 1 to 2 days in hospital, which is a huge advantage compared to the traditional open surgery. So where does this leave us? CERAB truly shows promise as an innovative approach that brings together both the minimally invasive benefits of endovascular therapy with durable long-term patency. It can also help us reduce major limb amputations in patients with severe critical limb ischemia. Even when complications like dissection or perforation arises, they can usually be controlled effectively with covered stents. Perhaps most importantly, CERAB offers our patients a faster recovery, shorter hospital stays, and an earlier return to normal life, all while sparing them the morbidity of extensive open surgery. As our experience grows, CERAB has the real potential to set a new standard of care in the treatment of complex iliac disease, and I believe that it is an incredibly exciting prospect. Thank you. These are some of our friends.
Do we have any questions? Well, one question for you, for the team. There are two cases that you couldn't pass the guide wire through. What did you do in those cases?
We did a ioto bifemoral bypass.
Okay. Crystal, you want to ask some question?
No, this is
Dr. Wilson. Dr. Wilson, go ahead.
Yes, I'm not very, I'm an OBGYN, so not very familiar with vascular surgery. I always worry about perforations when you're trying to get those little wires through the vessels. You said that the iliac perforation that was found was treated with a covered stent. How do you do that? What is a covered stent? How do you close up that perforation?
Looks like Dr. Oye. Dr. Oye on? Is that what I'm seeing?
Yeah.
Dr. Oye, did you hear Dr. Wilson's questions? Is he on?
He's muted.
So the questions are two. What is a covered stent, and how does it work to heal, to stop the perforation from bleeding?
Do you have any answer to that question?
Covered stent is basically a stent which is covered with a synthetic material. So there are less chances of complication from stent and less chances of free thrombosis.
And the hole that they will make is not a big hole. So once they put the stent, it tamponade the.
That's I understand. That tamponade
Because
is
during
important.
that time there would be quite a bit of bleeding, but
Sure.
these guys are so good at quickly recognizing it and putting the stent into a tamponade and shut off the holes. It's usually not a big hole.
Perfect. That's a great answer. Thanks for your help.
Good. Any other questions? Well, I have to thank the team for doing such a good job. Let's give them hands again. Okay. Well, let me just make some comment.
Yeah.
Well, the advent of the endovascular surgery is really exciting to me. I haven't been during the time when we used to do a lot of open surgery. I mean, I remember this kind of cases that goes home in 2 days. We stay in the hospital for about 10 days when we do ioto bifemoral bypass, which is a major surgery. Complication rate high, mortality rate high. And nowadays, I'm kind of just surprised when we have an aneurysm and they do an endovascular grafting and patient goes home the next day or sometimes the same day. That's so interesting to me because when we used to do open aneurysm surgery, you're talking about 6-hour surgery, 50 days stay in the hospital, a lot of morbidity. But right now, these vascular surgeons are just so good at it that it's very exciting to me. Do we have any other questions or comments? Is Cynthia still there? Miss Cynthia, the president of the Uzima Foundation?
Well,
is that Dr. Oye?
Yes, that's me, yeah.
Oh, good. Go ahead and make comment on the covered stent and how do you close the hole if you perforate the iliac? That was one of Dr. Wilson's question that Dr. White is already gone from here. So give us your opinion as to what that implies.
Very well, thank you. Again, excellent presentation by all the young doctors. I'd like to say again, the focus of the Global Grand Rounds is to ensure that they participate and improve their educational prowess as they go along in their training. With respect to the question of the covered stent material, there are two types of stents. Usually you have a bare metal stent and you have a covered stent. A bare metal stent is either made from steel or nitinol material. And the difference with the covered stent, it does have a wrapping around the stent, either inside or outside the stent, to prevent further leaks. And the wrappings could be PTFE, the standard Gore-Tex material, or it could be any other wall cloth material that is deemed safe, that's impregnated around the stent. So once we put a covered stent, even if you have a rupture, big hole in the rupture, and the moment you put a covered stent to that target area, and you inflate the balloon, and the stent opens up to the balloon expanding stent or the self-expanding stent, you automatically just close that hole. And that's the benefit of covered stent. So traditionally, many years ago, if the facility or the physician does not have a covered stent available, they'll be subjected to making an opening. They would have to, by the time you go make an incision, i.e. go to the iliac, patient may be dead. So now with covered stent technology, you can get that done very quickly. I'm talking about seconds and minutes. If the stent's readily available, since the wire's already there, put the stent in, with just a couple of minutes, you could avoid any disaster. So that has come very handy, and as a tool, as a armamentarium of our vascular surgeon team. So that's a covered stent. It works very well. And again, covered stents work well in the reason for the CERAB. We use covered stent also because those arteries calcified, and as you balloon those arteries, you run the risk of rupture. So covered stent also protects or minimize the risk of rupture when you do CERAB. So those are the benefits of covered stent. They do work quite well.
Great. Thank you so much. Great.
No worries.
Thank you, Dr. Oye.
Thank
you. We are reviewing the 4 charts that were on there. Let's start from the first one.
Yeah.
So let me just make a comment here. So that was greetings from
Cynthia, who is the president of the Uzima Foundation Board of Directors. Like I said at the beginning, I'm the vice president. We want you to know more about that. Down the road, we'll be able to give you the website to visit. But the Oye Global Medical Foundation is pretty well established, and basically trying to help improve the healthcare across the globe with emphasis on Africa and the diaspora. So I'm really happy that this presentation went very well. We were right on time. Do we have any other question or comment? And the student can make any comment that they want to make. No. Let me see the second chart. Where's the one?
There is one thing I wanted to add, something that I've experienced here. We had a patient that had a bypass surgery, and we had them on heparin drip. And then while I was following their labs, their platelets began to plummet. And they had platelets almost in the 9,000s. So my question to the students is like, why do you think that could happen? And in that situation, I switched the patient to bival and I stopped the heparin, and you could think about why I would have done something like that. And this also is something that comes on exams frequently. It was both on my step 2 and my step 3. So that's just for someone to think about.
So he's basically talking about heparin-induced thrombocytopenia. So I will want this young lady to comment on that.
The patient might have heparin-induced thrombocytopenia. So for management, we would first discontinue the patient from heparin, and then you would give a direct thrombin inhibitor.
And is there anything that you would want to order to establish the diagnosis of heparin-induced thrombocytopenia?
The serotonin gold status.
Yes, that's one of them, yes.
Yes, that's correct. So you should know about that. That's a very important questions in the exam. It looked like Dr. Wilson is raising his hand.
Yeah, thank you. I just, as the Dean of Clinical Sciences for Avalon University, I just want to thank Dr. Oye and your organization for making this possible. And I'm really proud of our students. I think they did a wonderful job with their presentations. Thanks to the good physicians and teachers there in West Virginia who help with the teaching and make this possible. I'm proud to be the Dean of Avalon and proud of our students today. Thank you so much.
Thank you very much, Dr. Wilson. We appreciate you. And we also thank Justin Amanda that said the conference was very well done. This time I will close the conference. There's no other question or comment. I would like Ibrahim to also give us a final talk. Thank you very much, everybody.
Thank you, everyone, for attending this conference. We appreciate your questions, your inputs, and your comments. This conference will be posted on YouTube if anyone would like to share it to anyone else to watch, or if anyone would like to go rewatch things that they've missed. So. Yes, Dr. Oye.
Dr. Oye, you want to make a comment?
Yes. Yeah. Thank you again. Excellent presentations from all the young doctors. I'd like to also indicate that our next Global Ground Rounds / Endovascular Conference for Africa and Rural America will be sometime in October. We'll post the exact weekend date in the next few weeks. Again, that will be in October, and after that, the last Global Ground Rounds for the year will be in December, sometime in December. Again, excellent job. Thank you so much.
Thank you.
Thank you. Thank you. Have a good day, everyone.
Good, guys. Nice meeting you all. I see you in the hospital once in a while.
Thank you.